Ulcerative colitis is a diffuse inflammation beginning in the rectum and spreading up the colon in a continuous pattern. Inflammation and ulcerations occur in the mucosa and submucosa. Multiple abscesses develop in the intestinal glands, and the abscesses break through into the submucosa, leaving ulcerations. The ulcerations destroy the mucosal epithelium, causing bleeding and diarrhea, which can result in fluid and electrolyte loss, protein loss, and pseudopolyps. Intestinal complications would be hemorrhage, strictures, perforation, and toxic megacolon, which is dilation and paralysis of the colon, and it is associated with perforation. Crohn's disease is a narrowing of the lumen with stricture development and may cause bowel obstruction. Microscopic leaks can allow the bowel contents into the peritoneal cavity. The ulcerations are deep and longitudinal and penetrate between islands of inflamed edematous mucosa, causing the classic cobblestone appearance. Peritonitis might develop. Abscesses are fistula tracts that communicate with other loops of bowel, skin, bladder, rectum, or vagina may also happen. The inflammation of Crohn's disease is nearly always found in the ileocecal region. The ileocecal region consists of the last few inches of the small intestine, the ileum, which moves digesting food to the beginning portion of the large intestine, the cecum. Crohn's disease can occur anywhere along the digestive tract. Other symptoms would be malabsorption, nutritional deficiencies, and complications might be classified as intestinal, localized to the GI tract, or extraintestinal, which is systemic. So looking at inflammatory bowel disease, the umbrella between Crohn's and ulcerative colitis, why would you think a patient with irritable bowel syndrome would receive an antidepressant? Tricyclics and selective serotonin reuptake inhibitors can help relieve abdominal pain associated with irritable bowel syndrome. Irritable bowel syndrome could be psychological and emotional, and it would be important to ask the patient to discuss their feelings. Patients with irritable bowel syndrome can take ibuprofen because it's not a stomach issue, and the nonsteroidals do help with pain. These patients should avoid high-fiber foods like whole grains and high-fat foods that would cause diarrhea. The best option is a low-residue diet. A low-residue diet would restrict dairy products, prune juice, anything high-fiber. Things that they could eat would be like cream of wheat, grits, puffed rice, white rice, noodles. A diagnostic test for irritable bowel would need to be that they have abdominal discomfort or pain for at least 3 months. Aminosalicylates usually are the first medicines used to treat inflammatory bowel disease. Sulfasalazine may be used for mild Crohn's disease of the colon, and some people are allergic to sulfa drugs and are unable to take sulfasalazine. Antimicrobials are the mainstay of treatment of pouchitis. Preliminary data suggests that rifaximin may be beneficial in treatment of acute ulcerative colitis and pouchitis, and mild to moderate Crohn's disease as well. Steroids such as prednisone also work by controlling inflammation. Steroids can help soothe the flare-ups, but they do have their side effects and are usually not used as long-term therapy. Immunosuppressant agents block the activity of the immune system, which may cause the symptoms. These drugs are sometimes used when other therapies fail to help patients or in patients who develop fistulas. For the most part, it takes 3 to 6 months for immunosuppressant agents to have their full effect. Side effects can be serious. It would include bone marrow toxicity, allergic type reactions, and liver disease. Biological therapies are medications that are made by living organisms such as bacteria or by living cells such as mammalian cell culture. Unlike systemic drugs that affect the whole body, biologic therapies and protein molecules are engineered to target specific cells or other molecules in the body. 3 biologics are approved for treatment of Crohn's disease: infliximab, adalimumab, and natalizumab. Infliximab, otherwise known as Remicade, is prescribed for adults with moderate to severe cases who haven't responded well to conventional therapy or have fistulas. It is also indicated specifically for reducing signs and symptoms and inducing and maintaining clinical remission in pediatric patients with moderate to severe active Crohn's disease who have had an inadequate response to conventional therapy. Because the symptoms of Crohn's can make it hard to get enough nutrients through food alone, and the intestinal inflammation may limit how much the nutrients are absorbed. On the left, you'll see an ileostomy. You'll see that it protrudes like this so that the liquid stool does not burn the skin. The stoma is located on the right side of the abdomen. An ileostomy involves bringing the ileum, which is the last portion of the small intestine, to the abdominal surface. When waste matter reaches the ileum, it is liquid, so appliance is needed to collect it. An ileostomy has high output of effluent and can cause electrolyte imbalances by loss of large amounts of potassium and protein. The patient may have difficulty learning to cope with an appliance that is always filling and the need to take in enough fluid, protein, and potassium to replace the lost nutrients. The skin around a high output ostomy may become excoriated if an appliance that protects the skin cannot be found. Ileostomy effluent contains digestive juices that, if left on the skin, will start to digest the skin, resulting in red, open areas. To prevent this problem, correct appliance fitting will need to stay in place, and it's very important for these patients. On the right is a colostomy stoma. Note that it is more flush with the skin and located on the left side of the abdomen. The mucosa should be rose to brick red. Pale may mean that it's anemic. Blanching, dark red or purple could indicate an inadequate blood supply to the stoma or bowel from adhesions, low flow, or excessive tension on the bowel at the time of the construction. Surgery may be done to remove part of the intestine. To relieve the symptoms, and inflammation tends to return to the area next to the intestine that's been removed, particularly if it's with Crohn's. Surgery may also be done to correct complications such as intestinal blockage, perforation, abscess, or bleeding in the intestine. For ulcerative colitis, a total proctolectomy with a permanent ileostomy would involve complete removal of the colon, rectum, and the anal sphincters. The anal canal is sewn shut, and the last portion of the small bowel is brought out to the surface of the abdominal wall. This is called an ileostomy, and it provides a passageway for bowel contents to exit the body, to avoid alcohol, caffeine, and other gastric irritants. Here's another visual of the procedure. Large bowel resection is also known as a colectomy. Removal of the entire colon and rectum is called a proctocolectomy. During 2 weeks before the surgery, they will need to stop taking any medications that would make it harder for the blood to clot. That would be like aspirin, Advil, Motrin, Naproxen, Aleve. They would need to stop smoking as it impairs the healing process. The top picture shows how it would be done if it was performed in 2 stages. In the first stage, a temporary ileostomy is created to divert the intestinal stream during healing of the ileoanal pouch. After a period of time, the ileostomy is reversed. Postoperative care. Most patients with inflammatory disease do need surgery at some point or other to repair the structural damage caused by scarring. Focus on assessing the stoma, protecting the skin, selecting the pouch, and assisting the patient to adapt physiologically to the body change. Observe for the type of stoma, color, size, location of the stoma, and peristomal skin. Monitor eyes and nose every shift, a calorie count, and weight. Probably will need a high-calorie, high-protein supplements as ordered, along with some small frequent meals. Administer IV fluids and electrolyte replacements as ordered. May need to give TPN. Now, their initial output might be as high as 1,500 to 2,000 in 24 hours, but observe for hemorrhage, abdominal abscesses, small bowel obstruction, and dehydration. Once a patient starts passing stool through the anus, stools are frequent and liquid. There may be accompanying urgency and leakage of stool. All of these aspects improve over time as the anal sphincter muscle strengthens and the pouch adapts to its new function. Stools become thicker as the small intestine absorbs more water. In addition, medications to decrease bowel activity and bulk-forming agents to thicken the stool may be given. Patients can help during this adaptation process by avoiding foods that may cause gas, diarrhea, and anal irritation. Careful skin care around the anus will protect the skin from the irritation of frequent stools. Continuing anal sphincter muscle exercises, like Kegel exercises, are also beneficial. After about 6 months, most people can expect about 5 to 6 semi-formed bowel movements during the day and 1 at night. The pouch takes up to 1 year to fully adapt. In most patients, functioning of the pouch continues to improve over time. A black stoma indicates necrosis. Remember, stomas should be assessed and color documented at least every 8 hours. On return from surgery, the stoma can appear a deep red, and the color of the stoma is checked and documented. Color is important because it reveals the status of the blood supply to the stoma. If the blood supply is inadequate, the stoma will turn black. The physician needs to be notified immediately. A stomal prolapse. A hernia is the most frequent complication of an ostomy and is caused when a loop of bowel pushes up through the muscle next to the stoma and under the skin. The one on the right is a prolapse of a loop colostomy. Both proximal and distal limbs have prolapse, and this may or may not cause an intestinal obstruction. A prolapse is when the bowel may sometimes telescope out. If the bowel continues to work, then it is not an emergency. A physician and an enteral stoma nurse may be able to replace the bowel back into the abdomen. If not, the mucosa of the abdomen may become injured, so a prolapse is then corrected surgically. Prolapses can be frightening for the patient, and it should be discussed as part of postoperative teaching. Loop colostomies and ileostomies are created to protect anastomosis or divert bowel content from diseased segments of bowel, like tumors or perianal fistula. Soon after formation, loop colostomies can often be recognized by the fact that they have a stoma bridge, which is removed at about 10 days post-op. They are potentially reversible. Because of the bulk of this type of stoma, can occasionally be difficult to manage. Tension at the stoma site where it is sutured to the skin can create poor healing or necrosis of the stomal skin edge and retraction of the stoma into the abdomen. This is called a mucocutaneous separation. Bleeding or hemorrhage may occur at the incision site or stoma site, and it's important to check the incision and stoma for bleeding, check the blood pressure and pulse frequently after surgery. The risk for infection around the stoma is greater because of the presence of stool around the new suture line. A toxic megacolon is an obstruction of the bowel ostomy and may occur as a complication after surgery. Ileostomy patients are instructed to chew their food well before swallowing because large pieces of food, such as olive or a large piece of meat, may be caught at the opening of the ostomy. The presence of visible peristaltic waves accompanied by high-pitched or tingling bowel sounds could indicate a partial obstruction. Toxic megacolon is a serious complication of ulcerative colitis. It is excessive dilation of the colon and may lead to intestinal perforation and death. There should be mild to moderate edema in the first 5 to 7 days post-op. Severe edema may indicate obstruction of the stoma, an allergic reaction to food, or gastroenteritis. Blood oozing from the stoma mucosa when touched is normal because it is so vascular. Immediately after surgery, there may be a small amount of serosanguinous drainage in the appliance. When the appliance is changed and the stoma is cleaned or touched when swollen, a small amount of bleeding may occur. Reassure the patient that a small amount is normal. Bowel functions are checked every shift to monitor for obstruction or ileus, for bowel sounds, distension, and abdominal tenderness. The presence of strictures, also known as string sign, predisposes the patient to intestinal obstruction. Abdominal distension may indicate that the patient has developed an obstruction of the large bowel, and the patient's healthcare provider should be notified right away. Low-grade fever, bloody diarrhea, and crampy abdominal pain are common symptoms of Crohn's disease. A sigmoid colostomy is formed stool consistency. Bowel regulations are possible with irrigations or diet. If they have surgery, it would be for cancer of the rectum or rectosigmoid area, a perforated diverticulum, or trauma. The patient could experience dumping syndrome, which would be vertigo, pallor, sweating, palpitations, and weakness. Dumping syndrome occurs after a gastric resection because ingested food rapidly enters the jejunum without proper mixing and without a normal duodenal processing. It subsides in about 6 to 12 months. Leave 1/4 of an inch of skin exposed around the stoma when determining the size to cut the skin barrier to prevent trauma to the stoma. The picture shows an ileostomy stoma, and it protrudes so that the liquid doesn't burn the skin.